Welcome. I see folks who are connecting to audio, so we'll give everyone a few seconds to do so. All right, welcome everybody. Hi, Danina. Hi, Carl. I see you.
Howdy, howdy.
Hey, hey, hey.
Wonderful. All right, well, we are at 2 past the hour, so I will go ahead and get started. Welcome to another capacity building series presented by one of Natura's CHW leaders in Johnson & Johnson. Today, we have an excellent presentation for you by our CHW leader, Gary Ringer. And for the past 2 decades, Gary Ringer has served his community as a firefighter for the great city of Detroit. The bulk of his commitment to the citizens of Detroit has been dedicated to the Cody Rouge and Warrendale community. In October of 2018, Gary had the honor of being selected to participate in the Robert Wood Johnson Foundation Culture of Health Leadership Fellowship, a 3-year leadership development program. Culture of health leaders are people working in every field and profession who want to use their influence to advance a culture of health where everyone living in America has a fair opportunity to live a long and healthy life. Gary is currently Director of Community and Economic Development at Joy Southfield CDC and representing the national CHW leaders in the Natura Advanced CHW project. Welcome, Gary.
Thank you. I appreciate your kind introduction, Michaela. Glad to see everybody in here. I saw Mr. Carl Rush chime in. I've been watching a few of his YouTube, so I'm kind of geeking out on that. Like, cool. So we'll go ahead and get started. Next slide, please.
You're running your slides.
Oh, I got it. That's right.
Love that. Love that.
22-year veteran firefighter, city of Detroit. Before becoming a firefighter, I used to build homes in the suburbs, which gave me an awesome opportunity to contrast vibrant and volatile. And within that being said, I realized that I was on that other side of the street. So once I became a firefighter and had the opportunity to see blight, not only that I knew from my community, but throughout the city, it sparked an interest in me as to why that was and what could we do to better remedy and deal with the situations which occur in our city. After a few years on the job of fighting fires and seeing the bulk of our work still standing year after year, and then just realizing that our community had other needs besides putting the wet stuff on the red stuff, I got my emergency medical technician license in 2005. And that gave me an opportunity to avail myself to other training, such as hazardous materials technician, as well as working with the Center for Disease Control and Homeland Security. And throughout that, my interest peaked in regards to health inequities and how can we remedy those and what can we do to better engage the community that we serve. 2018, wound up being accepted to the Robert Wood Johnson Foundation Culture of Health Leaders Program. And through that program gave me a further opportunity to network with like-minded professionals from across the country and met individuals from various sectors, public health, community economic development, you name it, and just really had a more sharper view of what needed to happen to create what we call at Joy Southfield those pillars to ensure that residents have the resources that they need to thrive. So within my role as Director of Community Economic Development, we're looking to create healthy people, which we feel equal healthy economy, and which will in turn equal a healthy community, and building out a true picture of community health and helping to minimize social determinants of health. When I first came into the role at Joyce Southfield, one of the things that I quickly realized within our Healthy Homes program was a need to be extremely more focused and intentional on the repairs that we were coming in and assisting residents with making. Most of those had only been minor repairs, plumbing, porch repairs, just minor drywall, painting, things of that nature. Pretty much whatever capacity that our volunteers, which came to us from mostly faith-based organizations that came in from out of town to volunteer in Detroit and wanting to help the community that we served as a federally qualified health clinic for the past 20 years. So within that being said, after looking at several applications, I noticed something that was consistent. Most of our residents who needed help were the most vulnerable, whether they had various disabilities, whether that be physical or emotional, or our elderly. And throughout that, people knew clearly within their summary on their application that they just needed some help making these repairs. And if they could have some repairs made, that it would increase the quality of their life. And I thought that was extremely important to see that mentioned numerous times on numerous applications. So through my equity lens, I thought it would be important for us to start looking at those inequities, those health inequities, and seeing if possibly the home could be contributing to some of the issues that were taking place or increasing other morbidities and health disparities within that household, whether it be mold, lead, et cetera, et cetera. So we created our Healthy Homes program, and we called it Healthy Homes RX, hence the prescriptive nature of dealing with some of those things. And one of the things we quickly noticed, our program kicked off in February of 2020, so right before COVID, but it was standing room only. Ran out of chairs, ran out of tables. Actually, at one point, had to stop letting people in the building that came to our kickoff event to find out about the program and how it could possibly benefit their lives. Once COVID hit, we saw that need from an indoor air quality pollution. So we got everybody essentially sheltering in place, but yet and still, if the sheltering in place could cause harm due to you not having a proper ventilation system at the home, or you already having health inequities and you living in a small area or whatnot, we saw the need for healthier homes more than ever. And then one of the other challenges within the program was the skilled labor shortage. And I say contractors versus volunteers, but even from the perspective of dealing with people who had this knowledge going into COVID, most people, didn't really realize the health gap within the communities until COVID hit. So as a Detroit Fire Department, we respond approximately to 165 emergency calls annually, and 80% of those are medical emergencies. And when I first came on a job, I would have never thought that. Our fire department is set up to where firefighters fought fires, EMTs, paramedics, they handled the medical emergency. Post bankruptcy, we condensed to where we had dual role firefighters who were either medical first responders or they had the opportunity to become EMTs. And remember, as I said earlier, I got my EMT license in 2005. So bankruptcy, post bankruptcy, 2014, 2015, is when we started to integrate medical runs within the service we provide as a fire department. Well, as firefighters, because we had already been providing this, but just totally separate. Our firehouse, one of the busiest on the west side of Detroit, Joy Road and Southfield, we went from, and even before we came on board, they selected certain firehouses to get the training first, not the training as far as being a medical first responder or EMT, but to actually come online, our fire trucks had to be outfitted for medical boxes and things of that nature. So now we can respond. We don't transport, but now we can respond to medical emergencies. So in the process of that, there were firehouses that came on board a little bit faster than ours. One of those in particularly was in our response area. So they're responding to our area because we're technically aren't outfitted to respond to medical emergencies because we don't have the jump box and certain things of that nature in order to provide medical service. So the first thing he told me was, hey man, when you guys go online, you're gonna be the busiest firehouse in the city. I say, oh, okay. So sure enough, when we finally went online, we went from 100 runs to 300 runs a month. And that doesn't sound like a lot, but that's a lot of runs. So we went from a few runs a day for fires or whatever the case may be. And when I say per day, it varies day by day. We may have 3-4 runs one day, we may have 8 to 9, but we consistently had 10 plus, sometimes some runs 18 to 20 runs a day. And most of those, once again, 80% of those were medical emergencies. So 80% of the population I serve is predominantly African-American. The median household income is a little over 30,000, and 35% of the population lives in abject poverty. One of we all know about cardiovascular issues, COPD, diabetes, the various ailments that a community is going to need help with. But for this presentation, I wanted to focus on 2 problem areas that a lot of the population doesn't have adequate information on. And that first one is carbon monoxide. And I'm sure you've heard of it before. It's colorless, odorless, tasteless, all that good stuff. Carbon monoxide poisoning is the leading cause of poisoning in the United States and accounts for more than 20,000 ER visits annually. 95% of all CO poisonings are non-fatal. 64% of the non-fatal carbon monoxide poisonings happen in the home. Only 14% of homes in the US have properly functioning carbon monoxide detectors. And even if they do have properly functioning detectors, they might not adequately be able to ascertain what other indoor air quality issues you may have going on. When gas burns, gas emits not only carbon monoxide, but it also emits nitrogen dioxide, as well as particulate matter. And each one of those issues, if you already have some form of health ailment, you're going to be susceptible to not feeling as well as you could feel within that environment. January 28th of 2021, as I said earlier, I'm on a hazmat team. So our hazardous material guys, we're looked at as an elite unit within the city. We most of the guys on the team have copious amounts of training to deal with various issues. And this particular morning, we were called to respond on Marlowe Street. Before we got there, we got an update of what was going on in the house. 6 of the residents were being transported to the hospital. There was one gentleman who was okay, but he was okay because he was up in the upstairs of the dwelling. So when we got there, before we even came in before we even broke the threshold of the house, I'm going to the side door, and our chief alerts us to, be careful. There's roaches in the house. Okay, cool. So I go around to the front of the house. Before I can even enter into the home, I can clearly see, deteriorated drywall, mold, possibly most likely from a leaky roof. And the place was somewhat disheveled. Needless to say, we did our assessment, saw what was going on, contacted DTE, which is our energy provider. They came out. They said automatically after they ran a few tests that the furnace would be decommissioned. And when we say decommissioned, that means it's done. It's not to be used. And the family was rushed to the hospital. So immediately my community development hat goes off, and I put my community development hat on, and I say to myself, okay, what can I do within my capacity and our program to assist this family? So sure enough, when I was getting off work that morning, I went in to Joyce Southfield, did my regular role, and once my day was over with, I gave them an application in the mailbox, talked to the gentleman who was there, and he alerted me to the status of the family. 4 of them were on their way home, and the mother was staying back, and one of the other kids were staying back for some other testing. Comes to find out, the mom had some other health issues she didn't know about until she went to the hospital. She filled out the application. I told her that we could possibly help her with an emergency furnace install. Give me a few days to find out what's going on. I'm gonna try to rush it as soon as possible. Upon the conversation, this was a Friday, I was getting off. Saturday, when I talked back to the residents, I had everything lined up for her to get not only a new furnace, but a water heater, HVAC system. I mean, they were giving her the work. So I'm ecstatic. When I talked to the resident stated that she had it fixed and that she don't need no help. She not used to nobody trying to help her. And I can clearly sense that, she may have been drinking. Cool, whatever. So I told her, hey, look, I apologize. I was just trying to help out. If you need anything, let me know. She said, okay, fine. So sure enough, I'm going to work Sunday morning and my phone is blowing up. Before I can even get to work, we have an application that we use on the hazmat team to keep us informed of what's going on. They had to respond to the residents again. So this is a few days later. I was over there a Friday morning. They're going back 2 days later, Sunday. The house was actually now not only a carbon monoxide hazard, it was also there was methane that was leaking, and the house was essentially about to explode. On our app, most of the gentlemen, like I say, are highly trained, and through their training, they've seen a number of situations. But the gentleman who was working that day, he didn't understand what the monitor was reading. So he shot a screenshot of it and he asked the group, has anybody seen this before? Sure enough, one of our senior techs chimed in and says, exit the building immediately. It's an explosive hazard. So for whatever happened to where it was a carbon monoxide hazard the first day, and from the time that she had somebody, whoever, could have been the same person that fixed the furnace, whatever the case may be, they came back, whatever they did subsequent to that, put them in a worse situation than they were in the first incident. So once I had the conversation with the homeowner, she adamantly, apologized, said she needed assistance. We were able to get her furnace and everything remediated that same day. And since that situation, we've helped her to put a roof on her house. Her children are doing well. And it was a situation that I think we can create other opportunities for. And the biggest thing is because Miss Eva still has some of the same behavioral health issues going on within the household that she had going on when we first met. But that's not to say that there cannot be some type of entity that can be in place to assist her in having resources to not only provide for her physical home, but then also her physical entity as far as her and the structure of her household. And I think it's a prime opportunity to where community health workers could be a benefit, even from the standpoint of just carbon monoxide detectors being at a residence. They weren't there. They didn't have detectors. And even if they did have a CO detector, there are limitations to carbon monoxide detectors. Most carbon monoxide detectors alert at 70 parts per million, which is a higher level as compared to a lower level. And a lot of people don't realize, even when your gas stove is off, it still might be emitting some type of pollutant within your home. So we all know most people, it's either a choice. You get the gas or it's already there when you move in. And so you operate a gas stove. And then also gas water heaters. There's numerous things outside of carbon monoxide that can be an issue when you're inside of your home. And unfortunately, most of the issues in our area, in the city of Detroit, we're in Wayne County, and Wayne County is our largest county in the state. And unfortunately, most of the pollutants, 80% of the pollutants that are in Wayne County are in the city of Detroit. So most of the people who are subjected to harmful carbon pollutants, like I said, outside of carbon monoxide, nitrogen dioxide, and fine particulate matter, as well as from formaldehyde and methane, which can be in these households where we know our most vulnerable are at. Asthma. Asthma is also something that affects the quality of life within the community that we serve. 2019, the rate of asthma hospitalization for Black residents in Detroit was more than 3 times the rate of white folks. And that reliance on the emergency department for asthma care was over 50% higher for children enrolled in Medicaid with persistent asthma in Detroit as compared to their counterparts in the state as a whole from 16 to 19. And this is the current 2021 report. So this is updated information. Another opportunity where I was able to intervene was a run that my fellow firefighters went on. And they said it was a divorced mother. She had 4 children. They just wanted to do something to help her out. They knew she was distraught about not only not having a hot water heater, which it went out, I believe, in December. Her furnace had just went out, and this was probably about a month after the other incident. So this was around early February. The guys wanted to get together and purchase and install the water heater and the furnace. I was able to, talk with them and say, well, hey, maybe we could, do something better than that. So once again, I put on my community development hat and reached out to the lady who had already reached out to one who had already exchanged information with one of the other officers. And we were able to coordinate, get our application completed. And we were able to install the same measures. We took out the furnace, put in central air, put in a new hot water tank, and followed up. And within that role of follow-up, once again, I think is a great opportunity for community health workers. 3 of the 4 children already had asthma, and they were essentially all sharing, whether it be the 2 inhalers and the 1 breathing machine. And they had other issues. Once again, open drywall, possibly could have been some mold. Same thing, roof issue, possibly, but it looked like she had just had a new roof when we came up. So it was probably something that was just underlying and still there and just wasn't remediated. Once we followed up before the summer, usually they utilize fans to, keep them cool. And, the fans are bringing in essentially whatever is coming in from outside. She said that from the first day that they turned on their central air unit, she could see her children breathing better. She could see their chests rising differently. And sure enough, later in the year, once the summer was over with, she said it was their best year as far as not using their inhalers as much. And when you hear those those opportunities that are being actualized, it helps me to realize why I got into this work. As a firefighter, I definitely enjoyed the aspect of going and assisting and helping and providing a service to the community. But as a community activist and supporter and grassroots boots on the ground guy, I see it as an opportunity to be proactive and create systems to where assistance is needed as soon as we know it's there, and we provide that. So within our Healthy Homes RX program, that was a core component of what we wanted to create. On the slide, it actually says home assessment, but the home assessment wouldn't be done by the community health worker. That'd be done by one of our home inspectors, somebody that has that building component, building knowledge, construction knowledge, and then the actual. So that would be the home assessment, but then the health assessment would be done by a community health worker. And through that program, we're hoping to not only understand what's going on in the house, we're hoping to create a relationship. And I think so often in our current climate, in our current communities, we don't create enough opportunities to create relationships. Folks want to shove a piece of paper in your hand, say, fill this out, go do this survey, whatever the case may be. And we consistently coming out with data that's reflective of what we already know, so why don't we create situations to where we can do something different than what we've done? And even on the Marlowe Street situation, where it was the carbon monoxide poison, when the homeowner was getting ready to get out the hospital, they asked her, she had a social worker that came and talked to her, and they said, hey, you got somewhere else to go? And she said, no. That was it. So that's an opportunity. And it's easy to understand how folks can be just overwhelmed with the work that needs to be done. But I truly think that collectively, if we look at our jobs as being inclusive of all, I think we can have a better opportunity to create opportunities to where folks can actually have some impact happen at their house, because it's happening collaborative nature. And in the short amount of time that I've been doing the work, from a paid perspective, I volunteered for years. I've been able to network with the Robert Wood Johnson Foundation, the Association of Black Psychologists. Within that relationship, we assessed the mental health needs that were prevalent after COVID. The National Association of Community Health Workers right now, just the opportunities to provide a better quality of service to urban communities, I think is overdue. Currently, Phoenix Fire Department, they already have a model to which they call their alternative response unit. And within their alternative response unit, they follow up asthmatics, and not just a firefighter. They have a community health worker, social worker. They have a team that responds and checks up on what's going on within the household, because as soon as the report comes out, you know what's going on. And as soon as you go to the hospital, you have another opportunity for somebody to help you to figure out what you have going on, or to follow up with you. Within our linkage of care, there's the silos, and I think the silos create more problems than necessary. So within that I think we have an opportunity to do something different. And I would love to answer any questions. I'm sure some of you folks have some. I hope so. If not, I can backtrack and give any other information in regards to how that service exchange between community health workers and first responders could look. So I'm hoping this can be almost like a breakout to where we just kind of collab and see where it goes.
Beautiful, Gary. We got some great feedback in the comments, a lot of gratitude. So I hope you have time to reflect on the comments in the chat. And if
Okay.
anybody has any questions, we've got about 30 minutes. So let's open the floor. Don't be shy. Come off mute, come off camera, and ask Gary some questions about his work, the future of CHW work within emergency responders, anything of that sort.
Don't be shy, please.
What's the funding source for the heating and cooling resources?
The funding source was actually energy efficiency repairs. So any energy provider, consumer energy, I don't know, I'm sure everybody has something different, but they have funds that they have allotted for energy efficiency assistance. And through that energy efficiency assistance, the EEA program, they're mandated to spend this federal money to do these repairs. And then even to the point of emergency repairs, if you have somebody that's in need, they just don't, and I'm not sure it would just be a capacity perspective, but you have programs all across the country that can service those needs within our community.
Hi, my name is Brooke, and I have a question.
Hey, Brooke.
So are you guys thinking about hiring your own CHWs, or will you be reaching out to organizations that have them and using them that way?
Yeah, that's a great question. Currently, within our capacity, I would love to say we could hire one, but we don't. So I would love to work with organizations and just work it out, not from a perspective of data collecting, but of people building and community building and trying to figure out, okay, can we service needs differently? Because we're still servicing the same need. They just coming to you at a different point in time. I'm saying that if we're coming in on the front end and seeing them, we can collectively together, hand that off to where we're working for the people as compared to, the systems working to the people.
Yeah, I think it would be great to do referrals to your community health workers, especially for persons who, I know you said something about you help replace a roof, or you help, we do that as well. We find resources to help replace roofs, windows. If the child or someone in the house is asthmatic, we find resources for that as well. So I think we will be a great follow-up resource.
Awesome. If you could put your information in the chat, I'd definitely love to talk.
Cool.
And like I said, this isn't new. It's programs that have been running similar programs across the country. And like I said, most of it aligns outside of the link because everybody's doing what they do. But it's all interconnected. We all live, multi-dimensional world. We all have different interests. We all are doing different things, but collectively, we know the real work is done as a group. You rarely getting a lot accomplished on your own. It's usually a collective nature within the work that's being done progressively. And I think from a holistic care perspective, as Michaela said in the chat, I think we can, kind of right some of the wrongs and get some real change created within our communities.
Gary, do you see some utility to perhaps facilitating CHW present, like groups of CHW meeting regularly with fire department or volunteer fire departments or even volunteer EMT sections, because I know that's how it's organized in some of our towns and our counties. So would you see utility in us also pursuing that sort of thing? Because I think some of the fire departments don't even know that CHWs exist.
I didn't know anything about CHWs until 2018 myself, when I became a cultural health leader with the Robert Wood Johnson Foundation. And it intrigued me just from a position of proximity. I saw the need and was seeing the need, but didn't know that there were other individuals that was attending to those needs from after we provide our first interaction with that household. So I think it would be extremely beneficial because we working on different ends of the spectrum of the link. And I think if collectively we work together, people, if anything, can get help sooner as compared to later, because a lot of times people still don't only know what they know. And until you experience a need, you may not know what resources are available to you and your family. Come on now, folks. I know I done put y'all to sleep. I must have went too fast. Let me see if I can go back and find something to talk about.
Hi, this is my name is Tasha. This was a great presentation. And my question is, do you see the role of the CHW as hired on, as maybe a community liaison person in that department of like the community relations department? Like, how do you see the role of community health workers growing within the industry of working with fire department? And even when I hear this, I even think about law enforcement too, because where I currently work, we have a department that goes out with the law enforcement for behavioral health problems, things like that. So it really seems like a great model, but I'm just curious as to where you see one, funding coming from that position, and then also number two, where you actually see the role hired in.
Great questions. I think the funding would come from the same places that other folks getting paid from now, right?
We would hope.
Yeah, we just pay it out differently. And I've said it a few times, and when I say it, it's not to say one or the other, but when we say defund the police, I mean, what does that mean? You know what I'm saying? We know what people think it means, but at the end of the day, what I want to say is fund prevention. How about we fund folks getting some preventative services beforehand, and then these other initiatives may not be as needed to where they're going. And not to say that their services aren't needed, but the funds could be switched because of the social costs that can be corrected by doing things just a little bit differently.
Definitely agree. Thank you for that feedback. Wish you the best. This is awesome. Great job.
Thank you. I appreciate you.
Hi, Gary. I have a question, comment. Do you think that would be worthwhile for residents to, as they learn about this, to advocate with their council people, take it to their mayors, and that way advocate for funding to be refunneled into more preventative services?
Awesome. I appreciate that. Great question. Absolutely. I mean, hey, you don't know until you know. And within that, one of the things I love about the notoriety that comes with being a fellow with the Robert Wood Johnson Foundation, which is a $40+ billion entity, endowment, being within the NASHWA, Community Health Workers National Program, and working with Johnson & Johnson within that race to equity position. I would think that there would be some type of influence that my voice can have at the table at trying to, do things a little differently, and doing it because you want to, not because you have to or you being forced to. And once again, like I said, when you look at 165,000 runs a year and 80% of those being medical, we could be on the front lines of creating some real systemic change within communities by just, like I said, responding differently. If response time is really something that's important, and when you're dealing with the nature of a fire, which doubles every few seconds, that's why we're on the scene as fast as we're on the scene, because the response time matters, right? So if we saying the response time matters, let's say it matters when it's most important, upon that initial interaction. And if other communities are doing it, I didn't look up the racial demographics of Phoenix, Arizona, but I know it's a progressive program. It sounds like it could have some merit. I'm sure some funders might be interested, because when we talk about the cost of emergency room visits, the cost of prescriptive medication, the cost of, from a social perspective, of not having people's needs being met when they need them met, and expecting them to navigate this maze within, the healthcare industry, I think is somewhat ridiculous, and we can do better than what we've done. And I don't want to be, like I said, on the back end of being forced to do something as compared to doing something ahead of time. And I'm not speaking as a fire official, and I'm not trying to throw anybody under the bus. I'm just saying, as far as through my little bit of time of doing community work, I think it would make great sense. And I think cross-sector collaboration is extremely key to provide some real results and some real benefits to communities, to improve the quality of life that they have and improve the culture of health within their household.
Thank you.
All right, Gary, we've got some questions in the chat. So Carl asked, or he said, you are doing great work. Have you talked about joint inter-program planning for disaster preparedness, helping develop community resilience? CHW should be a part of that as well as a response.
Oh man, that's a great question too, or statement, both. We actually the Department of Energy was looking, they just had a grant out for community resilience in regards to water emergencies and things of that nature. And due to my proximity, once again, to the work, I sit on the Green Task Force for the city of Detroit within our one of their committees. And they actually reached out to me because they knew I was a firefighter. They knew that I was interested in community building work. And they submitted a perspective to actually be awarded an opportunity for a grant to do some community resilience work, particularly around flooding, power outage and things of that nature. And they were able to link up with the Detroit Fire Department. So that relationship is hopefully blossoming. And hopefully that's something that can be a progressive initiative in the community. And within that initiative, they're looking to get away from gas emitting appliances and trying to create some solar infrastructure and things of that nature. So we headed in the right direction, but community resilience is really a part of that, as well as there's a organization in Detroit, Design Core Detroit. And they're in the process of currently doing what they call Month of Design. And within their design theme this year is unity. And it's centered around community resilience. And what do communities really need to thrive? From your mouth, from your voice, what will help you to build that resilience? Or why is it necessary for our community to remain resilient? So I'm looking forward to how that comes out this September, I believe. Yeah, September is Month of Design.
Awesome. We also have one more question from Nikki. She says, Gary, what advice do you have for new firefighters or first responders who feel like they are called to go beyond to impact their communities? So many have never heard of community health workers.
Yeah, great question, Nikki. Like I said, I didn't know anything about it until I was on the job 18 years. And then even I left the community to get that information and find out what community health workers do. And then talking to people and finding out the various titles with what community health workers do. And even I'm not saying that firefighters need to be community health workers. What I'm saying is we can collectively work together because we still have the same goal. We still serving the same clientele, the same population, our folks. And that's what I love about community health workers is being able to talk to people and provide resources to them and listen to them. And as somebody that's thoroughly ingrained in the community, me coming in, I'm not coming in and saying, hey, you need to take all your gas appliances out, it can kill you. You know, I'm giving you options that most times people don't know they have. And I think anytime you're formulating conversations and you're in community, you want to really be of community. And I think that's something that can't be faked. And, you know, firefighters that's from the community and want to serve the community, cool. But just like, you know, you go to work and then you go home, some people just want to go to work and go home. And I was thinking earlier, like what I did was done because I knew I had resources. Hey, they got some issues going on in the house. Let me try to provide some resources. So if everybody was empowered to know that they had an opportunity to provide that resource, I would hope that they would. If I go to get my brakes fixed and I leave out and I come back and the guy tell me, hey, we fixed your brakes, your rear view mirror looked like it was a little loose. We took care of that. We washed the car too. And we sprayed some air freshener in there. You'd be like, man, I appreciate that. You went above and beyond. But we just doing what we tasked to do. But within being a community health worker, most of the people, all the people that I've met go above and beyond, you know. So I know folks that go above and beyond as well in the work that they do. And I think from a resource perspective, if we knew more of what each other did, we can provide a better value to the same folks that we living and working and playing with.
Amen to that. I know I've seen a couple of requests for today's slideshow presentation. If you would like to just drop your emails in the chat, I'll copy and paste them into a BCC email with this attachment as we exit the presentation. Gary, I really wish you would have told the story about the young lady.
We done?
Yeah, do you remember remember you told me that she already had a young child and then something happened and then she was pregnant with another child and they were sleeping on a mattress.
Oh man, that would have been a tearjerker. That was a tearjerker right there.
Yeah, that one caught my heart.
Yeah. Do we got time? What time is it?
Oh, we got a few minutes. Go ahead.
I'm talking to you like we just on the phone. But yeah, I also in the capacity of what I do, I sit on our fetal infant mortality review committee. And unfortunately, within the city of Detroit, our infant and maternal mortality rates rival third world countries. So once again, just due to the having the opportunity to say that I have a affiliation and I'm a fellow with the Robert Wood Johnson Foundation, afforded me the opportunity to network with the health department and had the opportunity to sit and represent a different equity lens on with the issues. And I've been sitting on that board for about the past 2-3 years. but some of the cases of some of the children that are succumbing to housing and inequities and, you know, behavioral health issues that are known, it points to a breakdown in the system. And I know there have been a numerous, I've read articles and watched a few Google videos. I know that was one aspect of community health work that folks have been into. So I think it's a need, and I see the need from where most people don't. I had a baby in my arm and I'm trying to revive the child, and it happens too often in the city. And it was just a recent case to where a young lady who had multiple CPS cases, multiple, you know, every time you go in to you know, have a baby, you know, they taking your information. So multiple, each one of her pregnancies, she had substance in her. She didn't pass a UDS. Just multiple issues. The last young child had some lung issues. The mother was a smoker, never stopped smoking. So now the baby has to consistently have air. And this was the youngest child of the three. And the baby, since the baby was born with these issues and these inequities, the baby had to be in the ICU unit for a few months before the baby came home. I think about 4 months, 5 months before the baby actually came home, or 3 months. And then the baby came home for 5 months. EMS was called baby non-responsive. When they arrive, they can see the baby was hooked up to the air monitor. They tried to resuscitate the baby. They couldn't resuscitate the baby. Upon investigation, they weren't with the mother. They were somewhere else at a relative's house. The bed that they were sleeping on was being held up by milk crates, and there was a hole in the middle of the bed. So somehow, some way, and there's like 1-year-old, a 3-year-old, a 14-year-old, and then like an 8-month-old in the bed. And somehow, some way, I mean, you can only imagine, the baby was suffocated and didn't make it. But within that being said, how many CPS cases does there need to be some type of interventions? How many, you know, opportunities do we consistently see that we don't act, that we don't, you know what I'm saying, spray that air freshener, we don't, you know what I'm saying, you know, wash your car and do extra things to ensure that, you know, somebody's provided a level of service. Like, we're not talking about, you know, service providing. I'm kind of being facetious in saying that, but I'm saying, like, this is real work, like social work, people's lives. So whoever can provide a more empathetic system to where people are actually getting their needs met, I think we need to collectively figure out how we can effectively do that, because it's a lot of folks that's not making it, and I think we can assist them in making it and having and living better quality of life.
That was the story. That story is going to stick with me forever, so it has to stick with you all forever too. We have a grand finale question, Gary, and it says, what is a good strategy to network with our local fire and EMS teams?
That's a great question. I'm not sure. Yeah, we don't collectively get together in that capacity outside of, you know, anything that somebody does on their own. But I definitely think there could be some ramped up conversations to figure out ways to collectively serve differently. But I think within the nature of the work, like I said, 165,000 calls across 140 square mile city is a lot. And we tend to stay busy. So some of that stuff can get lost in translation. But I think people do the work because they want the work to be done effectively. And I think if you get some folks that are about doing the work and can affect some change and influence. I think influence is the biggest thing. Influence people to work differently. I think we could really make some strides in improving the quality of life in the individuals, communities, and their homes.
Yeah, that's a great response. I also thought of what the solution to this question might be. So I think that might possibly depend on what your region, state, local, community, fire department, and EMS departments are like. But I feel like as CHWs, we know the plan of action to do that. So first we would research who's involved, who's leadership, who we can speak to, public representatives, and then do our good old fashioned outreach and connection and networking and build that relationship. And then of course have all of our educational pieces of what CHWs do, how they help, and how they can assist in EMS programs right in front of you. And I think that that's part of it. You'll just have to develop like an individual relationship, and then hopefully that can continue through other sources. So I hope that answers your question, Hilda. And I just want to thank everyone for taking the time to join us here today. Gary, it's an honor to introduce you and to be here with you in this space and to see you shine so awesome with your work in this capacity. And be on the lookout for more natural events on our website, and we will get those slides out to you through email as soon as we possibly can. So thank you all very much and have a wonderful afternoon. You got some great feedback in the chat, Gary, so I hope you're able to take a peek at that.
Yeah, I'm trying to. Appreciate folks coming out.